For musculoskeletal, we're going to be talking about injuries to the system that can involve soft tissue, muscles, bones, tissues, ligaments, subacute tissue, or the bones themselves. These are going to be some of the possibilities you might see with your patient population. Contusions, and that's going to be bleeding into the soft tissue, often resulting from blunt force. That's going to be your bruises, but you would document them as a contusion. A hematoma, that is going to be a contusion with a large amount of bleeding, so they're going to have swelling under the skin from the blood. A strain, that's going to be a stretching injury to the muscle or muscles involving microscopic tears in the muscle, and basically it's been stretched too far. This is going to occur with injury, repetitive use, or when a muscle is forced to extend past its elasticity. This most commonly involves cervical regions of the spine and the lower back. This is going to present with stiffness, swelling, localized tenderness, and sharp or dull pain that increases with contraction. A sprain is going to be an injury to a ligament surrounding a joint, and that can cause some joint instability. Ligaments can be partially or completely torn and commonly involves the ankles and the knees. This presents with joint instability, some discoloration, heat, pain, and rapid swelling. This can be caused by inversion or twisting. And then we use RICE as an acronym to help patients to remember how to treat this. So R stands for rest. That's going to allow time for healing. You're going to limit weight-bearing activity for about 48 hours with this. And if they must, they can use a crutch to avoid weight-bearing, but they're going to use it on the uninjured side. So you want to make sure that they're using it on the appropriate side. Ice, not heat, is going to be used for the first 24 to 48. And that causes some vasoconstriction and decreases any blood pooling in the injured area. It can also help to numb it. Keep on no longer than about 20 minutes at a time, so you want to make sure that these patients have the ice on for 20 minutes and then off for 20 minutes. Also, wrap that ice in a towel. Don't just put it directly on the limb. Once that 48-hour time frame is over, they can switch over to heat as long as they're using ice in the beginning, and that can help increase blood flow and venous return. Compression, so this is going to be like an ACE bandage for compression wrap, and that can decrease the formation of edema, and that helps with the pain. Just be sure that if they're using an ACE wrap or any other type of bandage on there, if they experience any loss of sensation, numbness, tingling, discoloration, that wrap is too tight and needs to be loosened. And then elevation, that's going to promote venous return and decrease edema. So I usually tell these patients, like if they have a sprained knee or sprained ankle, if they're laying on the couch, elevate that knee or ankle above the heart. And then for medications for these, they can use anti-inflammatories, analgesics, and muscle relaxants. Initially with back pain, we want to take a conservative approach, and this is going to be short term for like about 2 days or so. We're going to put heat or ice to the affected area, warm moist heat for about 20 to 30 minutes, and if you use it too long, if you use it longer than that time period, they're going to have a rebound effect, and that's when vasodilation leads to tissue congestion and vasoconstriction. Cold, about 15 minutes, and then you can alternate between the two. So you're going to go back and forth from heat to ice. Medications, they can use NSAIDs if they're able to decrease inflammation. Muscle relaxants, such as cyclobenzaprine, that's Flexeril, Roboxin. There's all sorts of different types of options for that. Soma is another one. And then analgesics to relieve the discomfort. But really with this, more often than not, they're going to go with the NSAIDs and the muscle relaxers. And then modalities. And modalities means a lot of different things. This is, as myself as a patient and as a nurse, I would prefer to use modalities as a form of treatment, and that can be physical therapy, exercise, education. So think about proper lifting techniques with your back, weight loss, a corset or a brace, and I'll show you a picture of that on the next slide. So those can be like a TLSO, LLSO, there's so many different options for those, and that's considered a modality. Manipulation, that's going to be your chiropractic adjustments, acupuncture, massage would be another good one. TENS unit, which is a transcutaneous electrical nerve stimulator, and I'll show you a picture of that as well. That's a device that transmits low voltage electrical impulses through electrodes that you place on the skin. So this helps for pain relief. They can use it for about 5 to 15 minutes, and it's commonly going to be used by physical therapists. Think about, too, with your risk factors for patients and jobs that involve a lot of lifting, so you want to make sure that they're using proper lifting techniques, avoid sitting for long periods of time, and not stretching prior to activities. This is going to be a TLSO, and that stands for thoracic lumbar sacral orthotic. So think about what the letters are. So TLSO, it's covering from the top part, the thoracic area, all the way down to the sacral area. And this is used to immobilize the spine during the healing process. The average length of time for wearing these is about 10 to 12 weeks. This does vary depending on what the injury is or if the patient's had surgery. It just kind of really varies with that. It may be required for a short period of times, may be required for longer periods. So just keep that in mind. It's going to be determined by the physician and follow-up diagnostics like x-rays. The fabrication process for this usually requires a specialist. So in this area, for the pure area, we have CPO, which is comprehensive prosthesis and orthotics. That's one example of somebody that would fit this. They would come out and fit this to the patient. They can shape it, mold it, make sure that it's fit properly. They're a little bit more complicated to fit on women because of breast tissue, but you can see this one just kind of fits around that area. These are not very comfortable to wear, however, they really help decrease pain. So if they're not wearing it, they're going to want to when they get up. It's just going to hurt a lot less. This is an example of an LSO, so we can see it starts off a little bit lower on the back compared to this one, which is going to start in the thoracic area. So this would be a lumbar sacral orthotic. So this means that this person has a lower level of injury, so it's going to be lower than the thoracic area. A lot of them will work a little bit different, so when they're coming out, like CPOs coming out to fit these patients, they're going to be educating them on how to use it. If it's one that you've never seen before, just scooch in the room with them and make sure that you're watching so you can learn from it. And then this is a TENS unit. And these, holy smokes, they have come a long way from when I first started nursing. Now they just look like a smartphone. They come with 2 sets of wires, and you can put them on your muscle groups. They do supply extra pads with them, but it's going to be a limited amount. So if your patient's going to be using them long term, you really want to make sure that they have extra pads with this. And physical therapy is going to be teaching them how to use this. But I just want you to know that it exists, it's out there, and you could be seeing these on your patients. With joint injuries, your patient could be having a dislocation, and that's going to be an injury in which the ends of the bones are displaced out of their normal position, and a complete loss of articulation occurs. This can occur in any major joint, including the shoulder, the hips, the knees, the elbow, the ankle. They can occur in smaller joints too, such as the thumbs and the toes. I see it a lot with knees. Subluxation, that's going to be a partial dislocation, and the bone ends are still in partial contact. So sometimes this happens, like think about your stroke patients. When we get to the stroke section, they can't move their left arm at all, and they go to stand up, and it just kind of flops down at the side. They can suffer from a subluxation or even a dislocation from repeated wear and tear on that. So the causes of this are going to be mostly related to trauma. They can be congenital, such as the hip or the knee, or even pathological, like from disease, such as rheumatoid arthritis. Manifestations: pain, deformity, limited range of motion. They could be having some immobility or even numbness or tingling in the affected extremity. When we're talking about patients that have strokes, they're not going to have pain from it, but you're going to see an obvious malformation in the joint where it's going to appear subluxed or even dislocated. Management is going to be relieving the pain, so your goals are going to be pain relief, correcting the dislocation, and preventing any further complications. Diagnostics for this are going to be physical exam and x-rays. A lot of time when it comes to subluxation, physical therapists can diagnose this. They don't always x-ray that, but for the dislocation, they will. Shoulder joint dislocations are reduced, and that means they restore the shoulder to the normal alignment. And then they're immobilized for about 3 weeks, and then after that, they will start rehab. Dislocations of the hip, that requires immediate reduction to prevent necrosis of the femoral head and injury to the sciatic and femoral nerves. After reduction, the client is expected to maintain bed rest, and in some cases, traction might be required. Nursing diagnosis for this is going to be risk for injury, so you're going to be monitoring. You need to think about what you're going to be monitoring for. So you're going to be looking at the 5 Ps, so pain, neurovascular compromise, pulses, decreased or absent pallor with decreased capillary refill, paralysis, and paresthesias, which is going to be a change in sensation. And with these, you really want to maintain immobilization, and the whole reason behind that is to prevent dislocation again. So if it's a sublux issue, they might just put that arm in a sling, and they're not going to have to do anything more than that, like our stroke patient. Like every time they go to get up, put their arm in a sling so it doesn't swing freely and dislocate. With the fracture, that is looking at any break in bone continuity, and any of the 206 bones in the body can be fractured. These are going to be classified as traumatic, that's from injury, or pathologic, and that's going to be from disease. So for those, you're going to think about osteoporosis, cancer, osteogenesis imperfecta. There's many different examples of this. Simple is going to be when the skin is intact. It's also could be called closed. And open or compound, that's when the skin is broken. And sometimes when you see these, the bone will be protruding from the skin. This is quite a bit worse when this happens, and you have to think about the skin is protecting the body from infection. So if it's open and the bone is sticking through, you're going to have an increased risk for infection from bacterial entry. So those patients will need a high dose of IV antibiotics. Complete is the entire width of the bone is going to be broken. So if you think about if you take a pencil and you snap it in half, that's kind of what we're looking at there. And incomplete only involves a certain portion of the width of the bone, so it's going to be a partial fracture. Stable, this is a non-displaced fracture in which the bones were still going to maintain their anatomic alignment. And then unstable, that's going to be when your bones are displaced. So if this fracture is displaced, immediate intervention is going to be required to prevent any further damage. With this one, you can see right there, you can see the fracture. Hope you can see that. So this is probably going to be a simple, complete, stable fracture. So if you look at our terminology here, it is not through the skin. I mean, we're assuming it's not based off the x-ray. It's complete. It's all the way through, so it goes all the way through that bone. And it's stable. It's pretty much in place. I would say these bones are mostly in alignment. Here's some different pictures that you'll see of different examples. One of them is going to be like, this is an oblique. That's going to be a fracture line at a 45-degree angle. A spiral, this is going to be a curved line that curves around the bone. This happens with abuse, twisting injuries. So when we see these, they can often be a warning sign. However, you'll see in some cases that they can happen from twisting in covers too. So it doesn't automatically mean abuse, but we would investigate abuse if that kind of thing happens. Here we have a bone that breaks in many places. A compression fracture, that's going to be a bone that is crushed. This a lot of times will happen in the spine. You'll see a compression fracture. Impacted, that's going to be a bone, broken bone ends that are forced into each other. So there's an impact area, and that's why the fracture occurs. Depressed, let's see if there's a depressed one on here. I don't see a depression fracture, but that's when the bone is forced inward. A green stick fracture, that is a fracture that does not extend completely through the bone. And these are going to be really common in children. I don't think there it is, green stick. Sometimes these are more of a bending, just depending on what the situation is. A stress fracture, that's going to be a small crack in the bone, and that can be due to heavy weight or repeated stress of the bone. Sometimes you'll see that happen. The stress fractures will happen in people that are very athletic, people that are running, and so on. And then an avulsion, this one here is kind of easy to miss on an x-ray. So you can see that little tiny piece of bone that's come off. So with that one, that's going to be a fracture that pulls bone and other tissues away from the point of attachment. So you can see it's no longer attached. So this picture here is going to show the many manifestations that can occur during a fracture. There can be a deformity of the bone externally, even without it being open like this. So you want to rule out bone dislocation. You can have some swelling from serous fluid and bleeding, pain and tenderness, muscle spasms, direct tissue trauma like we see here, nerve pressure, and movement of the fractured bone. I bet you this one is moving around. Crepitus, that's going to be the grating of separated bone or even air entry under the skin, as in this case we're probably going to have some crepitus. Muscle spasms due to muscle contraction near the fracture, and then guarding. So think about what that is. These patients, they're not going to want you to touch that arm. They're going to be protecting it and holding it close. So that's going to be an involuntary action to protect that area. Ecchymosis, that's going to be from the blood into the subcu tissue. This patient's probably suffering some blood loss here, and that can be due to injury to the veins and arteries. Numbness, he's probably got some numbness going on up there, to nerve damage, pressure, or even nerve entrapment. And then also think about what you would see on an assessment if it's like a femur fracture. So the patient's going to have external rotation and a shortening of the leg in that case. So diagnostics for these, you're going to do an x-ray. We see the x-ray over here. That's a pretty terrible looking fracture. Bone scans, CBC, coag studies, they might be doing that to assess for blood loss and risk for bleeding. And you're going to be looking at your H&H. Sometimes these patients will require blood. Our treatment goals are going to be to stabilize that fracture. Before the fracture is stabilized, it's reduced, and that is a restoration to its normal alignment. They can be doing this a couple different ways. A closed reduction is when the bone is externally manipulated into the correct alignment. So the provider would externally, without making an incision, realign the bone into place. An open reduction is going to be done in surgery and surgically aligned. So an example of that would be an ORIF, which stands for open reduction internal fixation. So that would be one possibility for surgery. Then we're going to maintain alignment for these patients. So we're going to immobilize after injury. That's going to prevent any further injury, promote circulation, reduce pain, and correct any deformities with these patients. And reducing or maintaining alignment, that can be done with a cast, a splint, or traction. During the emergent phase, we are going to assess the patient's pulses, movement, and sensation. provide immobilization of the affected extremity above and below the deformity. So that means that we're going to immobilize it above the fracture and below it. Open wounds are going to be covered with sterile dressings if it's an open fracture. Bleeding is controlled with a pressure dressing. Bleeding is going to be a big concern with long bones, especially the femur. And you're going to need to replace blood loss as well as control that bleeding. Elevate the extremity, apply ice, and if there's any jewelry or clothing, you're going to remove that as well. If you cannot remove any jewelry, like say that it's a ring and it's a finger, they'll end up cutting that off. So signs of neurovascular problems are going to be decreased sensation, and that's going to be distal to the fracture site. So you're at work, you enter a patient's room, and you find the patient is on the far side of the bed on the floor. What are your actions going to be with this particular situation? Unfortunately, this is something that happens. You walk in the room, and it just makes your heart sink. They probably are impulsive, or maybe they thought they could get up and they fell. So your responsibilities for this, if the patient is on the floor, is you're going to immobilize the spine until a spinal injury is ruled out. You're going to assess for deformity, pain, and pulses. So you're going to get some help in the room. If they've hit their head, or you think they've hit their neck, or if there's any bleeding of any kind, you're going to take care of those issues. You're going to backboard. You can call down to ER, and they can bring a backboard up for you, and possibly even an RRT, a rapid response, depending on how severe the situation is. That's a little bit easier to read. So for traction, this is going to be the application of a straightening or pulling force for your patient, and this is going to help maintain alignment. So it's going to assist with alignment. Manual traction is going to be a hand pulling, so that would be you pulling on an affected extremity, and you would only do something like that under the guidance of a physician. Straight traction is going to be a pulling force, and that's going to be applied in a straight line to the injured extremity. The most common type of this is going to be Buck's traction, which I'll show you a picture of that here in a little bit. And that's going to be used for hip fractures. So the lower portion of the injured extremity is placed in a cradle-like sleeve, and a weight is going to be hung from the bottom of the traction frame. The advantages of these, they're pretty easy to use, and they maintain comfort. The disadvantage of it is going to be that you cannot use much weight because it will exceed the skin tolerance. It's going to be about 6 pounds per extremity. And this one is a pretty nice example of Buck's traction. Pretty padded setup there. So skeletal traction, that's the application of a pulling force to the pins that are placed under sterile conditions directly into the bone. So those are going to be pins that are drilled directly into the bone. Local anesthetic is going to be used for pin placement. The advantages of this, it's going to allow for more weight to be used than direct skin traction. So this is going to be, well, this is not direct skin, but this is still Buck's traction. The disadvantage is going to be increased anxiety, risk for infection from those pin sites, and discomfort. And then there's a whole section on pin site care with these patients. So some of the things you're going to do is you don't want to remove crusting from around pins because this provides a natural barrier from bacteria, and there is a treatment that we do with flossing them with gauze, which I'll see if I can find you a video for that because it's kind of hard to explain it to you without showing it to you in person. Balanced suspension traction is going to involve more than one force of pull. Several forces work in unison to raise and support the client's injured their injured extremity off the bed and pull in a straight fashion away from the body. So we see that one here. The advantages of this is going to be increased mobility without threatening joint continuity, and the disadvantage is going to be multiple weights make the client more likely to slide in bed. This is used with femur fractures. And then halo, let me see if I can find a halo for you. So let me get this moved. This is going to be an example of a halo device there, and screws are placed through a halo type bar that encircles the head, and this is going to either be attached to the bed or rods that are secured to a vest worn by the client. So you see this one is secured with rods to the client. The other thing is there is a picture right here of where those pins are going into the skull. So back to where you need to be. Go back here for a minute. So again, this is going to be your straight traction. This is going to be skeletal with pins. And this is balanced. So balanced, skeletal, box, or straight traction. For traction care, we want to maintain the pulling force and the direction of the traction. So you're going to maintain the line of pull, center the client in the bed, and maintain body alignment. So that's very important. Sometimes when these patients are having an acute flare-up of pain, a lot of times their body is not in alignment, and restoring that can significantly reduce the pain. Maintain and make sure that the weights are hanging freely and don't touch the floor. So if they're hanging on the floor or resting up the side of the bed, they're not providing adequate traction for the patient. You're going to allow for counter traction. In most cases, the patient's body weight will provide this, and you do not need to allow the patient's foot to be flush with the footboard of the bed. So you don't need to do that if the patient's body weight is adequate to do that. So you're going to help apply counter traction by slightly elevating the foot of the bed. Assess for your common complications of immobility, skin ulcers, DVTs, pneumonia, paralytic ileus. And in skin traction, just be aware that you never want to remove the weights. You're going to be assessing skin and pen sites. If the patient has skeletal traction, you want to assess those pen sites frequently. Provide pen site care as instructed. And again, I'll find a video for you to watch on that. You're going to watch for signs of infection, redness, increased tenderness, drainage, but you'll expect some amount of clear drainage from that site. In skin traction, make sure you're assessing the skin frequently. Bony prominences, provide padding like what we see in this one. That's quite a bit of padding there. And protective dressings. Perform your neurovascular checks frequently. That's going to be essential with these types of patients, especially if they're in skeletal traction. You want to remove weights only when intermittent traction has been ordered to alleviate muscle spasms. So make sure you do those neurovascular checks. You're going to be checking for your 5 Ps again. So the 5 Ps again are going to be pain. That's going to be an indicator for neurovascular compromise. Your pulses, are they decreased or absent? Pallor with decreased capillary refill, paralysis, and paresthesias. So it's going to be a change in sensation. So another treatment option for certain patients is going to be surgery. So surgery is going to be needed if it requires a direct visualization for the repair. So if the physician needs to see the bone in order to repair it, they will have to open the patient up. Other reasons for surgery could be a threat to vascular integrity or potential for long-term complications. So this is going to be an example of an open reduction with internal fixation. It's also called an ORIF. And the bones are visually inspected and aligned. So when this fracture occurs, the surgeon's going to open the patient up, visually inspect the bones, and put them in place. And then the hardware is going to be entirely within the body, so it's going to be enclosed. So after the hardware is placed, then the incision is closed, and there's nothing visible outside. So if you're taking the ORIF, open reduction internal fixation, literally, they're going to open the patient up, reduce the fracture, internally fixate it. So see how this rod is in place, it's internally fixated by this method or by this method, and then they're going to close the patient back up. That's going to be different than an external fixation where the hardware is on the outside of the body. For the ORIF, you're going to monitor for signs and symptoms of infection, vital signs, temperature, increased respirations, tachycardia, and look at your lab values. So look at your WBC count. An external fixation over here on the right-hand side, the external pins are placed through the skin and into the bone above and below the fracture. So we see the fracture right here. We have our pins placed above and below it. And this is done to immobilize the bones. The pins are attached to an external fixator device, and that's going to maintain the alignment. The pins require care similar to that of skeletal traction pins that we talked about earlier, and the client should be monitored for signs of infection. So what would you be looking for with this patient for signs of infection? Do you think about everything we covered here with our vital signs, our temperature, our tachycardia, or increased white count? Also consider any type of drainage they could be having from the pins. Clear drainage is normal, pus would not. So just make sure that you're doing a thorough skin assessment with these. They're going to be doing an external fixator with patients that have multiple fractures with extensive soft tissue damage. The external fixators can also be done with leg length discrepancies due to congenital defects and bone loss due to osteomyelitis or tumors. The advantages of this include that it's immediately stabilized. This allows for 3-plane correction of the injury, minimal blood loss as compared to an open reduction. It also allows for early mobilization, permits wound care for open fractures. The fixator is said to increase independence while maintaining mobility. For management, you're going to be performing a cold spa with these patients. Usually the pain is going to be identified as severe, sharp, aching, or burning. Assess the location, character, and duration. So cold spa is going to be something you're going to be doing with these patients. For medications, you could be giving Toradol. Ketorolac is another name for that. That's going to be an NSAID. So just think about what your primary concern is going to be with these patients if they have decreased kidney function. Analgesics, narcotics by PCA or epidural PCA. A lot of times those are going to be given sub-Q. You're going to teach you're going to teach your patient to request that pain medication before the pain becomes severe, because a lot of times they can get a hard time getting caught back up on pain medicine if they wait too long. Reassure the patient they won't become addicted. A lot of times these patients are really concerned about that, and most patients are going to require oral analgesics by the 3rd or the 4th day. And keep in mind that medications like NSAIDs are going to mediate inflammation as well as provide an analgesic effect. So you're going to have a dual purpose there. You can also elevate the injured limb. That's going to increase venous return, thus decreasing edema as well as pain. Monitor and empty any drainage devices. Sometimes these patients will have orthopats, which is a type of surgical drain, a GP drain, and that's to help remove some of that fluid there to decrease tissue accumulation and pain. You want to make sure that they can wiggle their toes or fingers. You want to reposition to alleviate pressure and teach alternative methods of pain control in case the analgesics and the NSAIDs aren't enough. So relaxation, guided imagery, distraction, ice, and then notify the physician if needed, if there's any type of complication such as infection or neurovascular impairment, because we don't want these patients to end up with loss of limb. In addition to measuring for pain, we want to make sure that we're including the following. We want to make sure that we're doing a good assessment on your patient. So again, the 5 Ps, they're very important in this section. So pulse, paresthesias, that's going to be your tingling, paralysis, pallor, and pain. Lung sounds, you're going to be watching for pneumonia. A lot of times their mobility is impaired. Bowel sounds, watch for potential paralytic ileus. Drainage, that can be a sign of infection. And neurovascular assessments, pain, sensation, numbness, tingling, skin temperature, cap refill. I know I keep talking about the 5 Ps, but it's pretty important. Medications, give them some stool softeners, especially if they're on an analgesic. Anticoagulants, Those are going to be important to help reduce complications like DVT and PE. A lot of times with these patients, the physician will put them on either a low-dose aspirin or 325 aspirin, or even Xarelto and Lovenox to help prevent complications. And weight bearing is ordered. So some of these patients are going to have toe touch weight bearing. They might need an assisted device. Toe touch weight bearing is pretty hard to maintain. So literally they can only put their toe to the ground. And physical therapy should be really ordered on those patients to help out with that. Encourage early mobilization, and that's to decrease complications of immobility such as DVTs, kidney stones, pressure ulcers, pneumonia, ileus, loss of appetite. You can also get them SCD and ankle pumps. I wouldn't put it on the fractured leg, but you could put it on the non-fractured leg. Instead of spirometer 1 to 2 hours, that also helps to decrease the risk of pneumonia. So we're probably going to be talking about neurovascular assessments and the 5 Ps with this one again. The purpose of a cast is going to be immobilizing the joint above and below the fracture to maintain alignment and promote healing. So same type of function that we saw with our external fixators. Casts are going to be applied to if the bone is aligned or after reduction. So if the x-ray shows that there's alignment, they could just put the cast on, and if not, they could reduce the bone, maintain the alignment, and then cast the patient. The cast is going to be applied over a thick layer of batting. It kind of looks like a different type of gauze that they put underneath here, and you can kind of see it peeking out the top there. You're going to perform your neurovascular assessments again. Don't palpate these casts while wet. That can distort the shape and cause pressure, especially with these fancier, more modern casts that we've been using lately. Plaster casts, they might take about 48 hours to dry. Fiberglass, pretty quick. They dry in about an hour. So after they're dry, you can palpate for hot spots that can indicate any underlying infection, report any drainage with these patients, and then teach your patients about the do's and don'ts of cast care. So you don't want to place any objects in the cast. They get pretty itchy after a while, and you'll get patients coming in that are sticking clothes hangers down there to scratch their leg or rulers. Just educate them about doing that. They can use a blow dryer on a cool setting to help relieve the itching, but just caution them about getting that too hot. Keep the cast dry if it's plaster, and you can wrap plastic around that as needed. They actually make special devices now that are like clear bags that have elastic at the top, so you can put it over the casted leg and take a shower. If the cast is made with fiberglass, dry it with a blow dryer if it becomes wet. And again, the 5 Ps. We'll be talking about that a lot with this section. Patient should expect x-rays at the doctor's office. They're going to follow up with these to make sure that the bone is healing properly. And the cast is going to be removed with an oscillating cast saw. It vibrates, but it doesn't rotate. So if the patient's is using a sling, the patient should wear it so that the weight is evenly distributed. You're not going to use a sling with something like this, but if they have one on their arm, you want to make sure that the weight of the arm is completely distributed across their chest. And then elevate the cast above the level of the heart for the first 24 to 48 hours, and that's going to help with surge swelling and prevent compartment syndrome. Next, we're going to talk about some complications that can result from fractures, such as compartment syndrome, fat embolize, infection, loss of skeletal integrity, and nerve involvement. Compartment syndrome occurs when an excess of pressure in a limited space constricts the structures within the compartment, and this is going to reduce circulation to the muscles and the nerves. Causes of this can be hemorrhage. It can also be edema within the compartment, and external compression of the limb by a cast that's too tight. So that's one of the reasons why it's very important to assess those casts. Manifestations of this, well, it usually occurs within about 48 hours of an injury, and that's when edema formation is going to be at its peak. So what you're going to see, you could be seeing some cyanosis with this. A lot of times what I would see first is going to be paresthesias. So they're going to have burning, tingling, or loss of sensation. They could have some weakness caused by nerve damage, diminished reflexes, oh, and severe pain too, especially when the extremity is passively flexed. So that's going to hurt quite a bit. Eventually, these patients are going to have renal failure. They could develop rhabdomyolysis, and that's due to a release of myoglobin from the breakdown of muscle cells. And that's going to be a protein that is toxic to the kidney. Distally, these limbs are going to be cold to the touch. They could have decreased or absent pulses. And this is a medical emergency. So the treatment for this is going to be to relieve the pressure. So if the cause is external, treatment may be removal of whatever device is causing it. So if in the case of a cast, you would contact the physician to get that cast removed. Sometimes what they'll do is they call it bivalving, and that's where they split the cast down both sides and then they Velcro it together. It relieves the pressure and allows for visualization of the limb. If it is internal, they're going to be doing a fasciotomy with these patients, and that's where they're going to do an incision of the muscle fascia that's involved in the compartment. So that might be necessary. After the fasciotomy, the incision is left open. So these patients are going to have an open incision, and a passive range of motion exercises are performed on the extremity. This makes them extremely high risk for infection. And here we see examples of a fasciotomy. So dressing care for this is going to be wet, sterile dressings, and they're going to pack it into the site. You don't want to dry this out. So the goal is to close it within about 4 to 5 days after the swelling goes down. Skin grafts might be necessary to cover depending on how much edema is going to be there. And if you suspect compartment syndrome, the extremity should not be elevated above the level of the heart to ensure adequate perfusion. And the reason why we're doing this is we don't want to cause any decreased blood flow to that area. So again, with patients with compartment syndrome, you're not elevating the limb. You can see also on this patient, they have little X marks on them. Likely they're having to Doppler the pulses on these, so they're probably using a Doppler on that area to assess for pedal pulses. They probably just have pulses that are too weak to be felt. When a bone is fractured, this can cause increased pressure within the bone marrow, and this can exceed capillary pressure. This can result in fat globules leaving the bone marrow and entering the bloodstream. Once these are released, these fat globules combine with platelets and travel to distant sites like the brain, the lungs, the kidney, and other organs. Risk factors for these are going to be fractures of the long bones, hip replacements, major trauma, especially if there's a case of delayed stabilization. Manifestations for this, these usually occur within about 48 hours following long bone fractures. They could have neurological dysfunction, and that's going to be due to altered cerebral blood flow. It will result in confusion and changes in level of consciousness. They could have respiratory distress, so shortness of breath, tachypnea, hypoxia, and that's going to often be the first indicator. So respiratory is going to be where you're going to see this first for a fat embolism. They could potentially have petechiae rash over their chest, their axilla, or their upper arms, and this is going to be from a blockage of the capillaries by the fat globules. This is what is going to discriminate it from a pulmonary embolism, so it's going to be different. Management, possible intubation for these patients with mechanical ventilation, maintain fluid balance for shock, IV fluids, corticosteroids to decrease inflammation for cerebral edema, and reduce any type of bronchial spasms they could be having. But mostly what we're going to be focusing on for these is going to be prevention. So early immobilization, surgical stabilization, and early identification and treatment. DVTs, these are going to be linked to immobility, damage to the vein, and possibly hypercoagulopathy. So it just depends on your patient's specific situation. So what are the manifestations for these? We're going to have some swelling. We can see that this leg is quite swollen. pain, tenderness, redness in this case, and warmth. Sometimes the redness is going to be localized right over the spot where the DVT is, and sometimes you're going to see it on the whole leg as we do here. So diagnostics can be a physical exam. They are going to get follow-up with venous Dopplers. A D-dimer, however, that one's really falling out of popularity. More often than not, they're going to go with the venous Dopplers. If a D-dimer is positive, it is a high probability that there's a clot present, and about 5% of those are going to turn into DVT or to PEs. Treatment for this, the best treatment is going to be prevention. So we want early ambulation with these patients, anticoagulants, anti-embolic stockings, SCDs, ankle pumps, deep breathing. And if it's present, they're going to put the patient on bed rest at least until they get anticoagulants on the board, possibly thrombolytics, although not that often, and possibly an IVC filter. So if you have a patient that's getting multiple clots over and over again, they might consider an IVC filter placement. They might also use Lovenox, Rixtra, Coumadin, and heparin. So be aware that you'll have to monitor your lab values. Your Coumadin would be your PT-INR, and the heparin would be the PTT. So holy smokes, infection. That is one bad looking leg there. Gas gangrene. This is going to be a medical emergency treated with debridement and excision with amputation in many cases. So if they've got this going on, this person is likely going to lose their limb. Gas gangrene of the right leg and pelvis. This is what you're seeing here. This shows swelling and discoloration of the right thigh. The patient, and at the same time as the photograph was taken, was experiencing some shock as well. Underwent a hemopelvectomy, so they've actually lost part of their pelvic, so that's a high pelvic amputation, and died less than 8 hours later. So this is a very urgent situation. So this is why we want to prevent infection with our patients. So infection that can affect the wound or the bone. Pathogens can be Pseudomonas, Staphylococcus, Clostridium, and the Clostridium is the one that's going to lead to the gas gangrene like what we see here. So the pathogens are going to be carried in the blood from remote sites. They could have direct contamination, such as an open wound. Think about your patient with the fasciotomy that we looked at earlier. They could also be an extension from an adjacent soft tissue infection like cellulitis. Osteomyelitis, that is going to be an infection of the bone, and it's most often going to be Staphylococcus aureus. This can be staged, so it's stageable as acute, subacute, or chronic. The causes of this are going to be a couple different things. So we could have hematogenesis, and that's where pathogens are carried in the blood from remote sites. We could have direct contamination again from open wound. That's going to be the most common, and then again from cellulitis. So there's just the same amount of causes for osteomyelitis as what we saw in the earlier slide. Manifestations, they're going to have some bone pain, and that's going to be mostly at the end of the bones. Tenderness, they could also have some lymph accumulating in the affected extremity. They could have purulent drainage and ulceration at the involved site, so swelling, erythema, and swollen lymph nodes. And the general manifestations could be nausea, vomiting, tachycardia, fever, chills, malaise, and changes in their blood count. So think about their WBC count. Diagnostics for these, they could do an MRI, a CT, a bone scan, ultrasound. They're going to take blood tests to look at the WBC count. They could do a SED rate or even a positive bone or tissue culture or blood cultures. Treatment for these are going to be, for either acute or chronic, are going to be IV antibiotics. So if they're in an acute stage, they could get IV antibiotics before transitioning to PO. These patients are going to be on antibiotics for about 4 to 6 weeks, so they're going to need a PICC line. So they'll be going home with a peripherally inserted central catheter. PICC line for treatment. So they're going to be educating the patient and the family on how to use that PICC line and how to use the IV pump. They could have possible surgical debridement if it's chronic with invasion of necrosis of the bone. They could end up with an amputation as well. They can also try hyperbarics with these patients, and that's where they're going to be in a hyperbaric chamber and breathe 100% oxygen at higher pressure rates into that you would see in a normal atmospheric pressure, and that's going to help with healing. Delayed union, that is prolonged healing of the bones beyond the usual time, and this is going to usually occur in the long bones. A non-union is a persistent state of a non-healing bone, and the causes of this they're quite extensive actually, so there's going to be more than what I list here, but I always think of diabetes when I think of delayed healing. So presence of chronic disease is going to be an issue. Diabetes, of course, age, infection, altered immunity, peripheral vascular disease, and smoking. Those are just going to be some of the few. So treatment's going to be internal fixation with bone grafting. They could try electrical stimulation, and that's going to be invasive or non-invasive with lead wires. So they could be internal or external, just depending. It's contraindicated with infection, but it increases osteoblast activity, and that contributes to new bone formation. And then sometimes they'll give growth hormone to stimulate bone growth. With amputation, we've got a partial or total removal of a body part, in this case the leg. Some of the causes of this is going to be peripheral vascular disease, untreated infection, and trauma. Couple different types here. We've got an open, it's sometimes also called the guillotine. This is done if there's infection, and then it's closed when the infection is resolved. This one's going to be a closed flap. So when they amputate this limb, they'll leave a longer piece of skin like on the top of the leg, cut the bone off shorter, and then fold that piece of skin over. And then there's so many different options on where they're going to amputate. One of the most common terms is going to be AKA and BKA. So AKA is going to be above the knee, so above the knee joint, and BKA is going to be below. Now, one of the significant things about the differences between a BK and an AK is the ability to walk. So if the patient still has their knee joint intact, the likelihood that they will walk again is pretty high. If they amputate above the knee, that goes down significantly. Not impossible, just makes it a lot harder. So post-op care with these patients, you're going to provide pain control. The big issue with these patients is they still have quite a bit of phantom pain. Even if they weren't having pain in that limb before, once that limb is gone, they're going to have some phantom pain. So you want to give them narcotics for that if it's not controlled well with that, because sometimes narcotics don't work for phantom pain. Contact the physician. They might be able to get something like gabapentin on board. Antibiotics, so they're going to need antibiotics post-op, stool softeners due to the constipating factors of narcotics, and then possible steroids to reduce edema, although that doesn't happen as often. Compression, you're going to reduce you're going to reduce edema with the compression of the limb. So you want to help to shape the residual limb for a future prosthesis. Deep breathing, reposition every 2 hours to prevent skin breakdown, avoid prolonged elevation, because if that leg stays in the upright position, they're going to get a contracture. So sometimes PT and OT will come in and have the patient lay on their stomach to help with that. Complications, chronic stump pain, they could have a neuroma formation. If that happens, they're going to have to treat with meds and nerve blocks and maybe a TENS unit. Sometimes they'll have to go back in and revise it. Phantom limb pain. So this is not going to be the same thing as phantom limb sensation. They could have phantom itching, tingling. Sometimes I've heard patients saying they felt like they stubbed their toe. So it's just an alteration of a feeling. So when phantom limb sensation is painful, that's going to be known as phantom limb pain. If it's just a random sensation, it's phantom limb sensation. The exact cause of this is going to be unknown. Sometimes they'll give beta blockers to dilate the peripheral vessels to help with this, such as propranolol, or even sometimes Neurontin, like I mentioned earlier, to help with it. If that doesn't help, they'll refer these patients to the pain clinic. Flexation is going to be another complication due to contractures, so we really want to make sure that we're doing range of motion, get PT and OT involved with them. We already talked about elevating the stump. We want to also discourage prolonged sitting, and you want to have the client lay down several times a day and possibly lay on their stomach. A lot of these are going to be, the goal is to get them walking again, so your interventions are going to be geared towards that and pain control. Okay, so the last slide I have on here is going to be a shrinker. They're called stump shrinkers. I prefer the term residual limb. It just sounds a little nicer for the client. And you can see here there's a couple different types. So this is going to be kind of like an ace wrap. This one fits around the waist and goes around the limb here. So when you're applying these, you're going to put the dressing on your patient, and I'll find some videos on how to wrap a residual limb. But you really want to get 2 nurses or a nurse and a CTA to put these on, because on a fresh incision, this is like putting on a tight glove. You really want to make sure that you have it stretched out on either side before putting it on there, because it's quite painful. This one is not as stretchy and doesn't hurt as much as this one does. This is like a soft white sock. So this is not really a shrinker, it's a sock. It's a spacer that they often use with a FlowTech over it, which is a plastic device fit by a prosthesis company like CPO that's going to come in, and that just helps protect that residual limb from damage. Most of the time with these patients, they fall, about all of them are going to fall at some point, because they wake up in the middle of the night and forget they don't have a leg and try to get up and walk. So we're trying to protect that area by covering it with a plastic device called the FlowTech. Let me see if I can find a picture of that. So this is going to be the FlowTech. So again, this one, shrinker, that goes on after your gauze dressing. So gauze dressing, shrinker, spacer, and then the FlowTech, which is going to be this one right here. And that's hard plastic and helps protect it. There's a little piece of foam down in there too, in case the patient bumps her leg. Okay, that's it for the first half of musculoskeletal. I'll get the second one uploaded to you shortly.